Thank you very much for joining us. This presentation is not technically a trauma case, although it was a traumatic event. As you will see during the presentation, this was something unusual, but with current technology, we believe that this is something that we will be seeing more frequently. Dr. Tian, she is the chief resident. She was the chief resident in the trauma service at that time, and she was doing this case, so she will be the one presenting this. So, Dr. Tian.
Good morning, everyone. Thank you all for being here. So like Dr. Hojman mentioned, today we'll be talking about an unusual traumatic mechanism causing intra-abdominal bleeding. This is a 63-year-old female. She had an extensive cardiac history, and she presented as a planned admission from neurosurgery clinic for a Coumadin washout prior to her spine surgery. This is her past medical history listed here, notable for coronary artery disease with multiple previous myocardial infarcts. She had 3 prior stents placed to the left anterior descending.
You're mute. Oh, yeah, that's okay. Yeah.
And right coronary artery ×2. She also had a prior stroke, ischemic cardiomyopathy, hypertension, a prior DVT, a question of heparin-induced thrombocytopenia, type 2 diabetes, and hyperlipidemia. Her surgical history is also listed here, notable for an IVC filter placement, and here are her meds listed. 2 days into her admission, she developed sudden cardiac arrest. She was found to have new ST elevations in leads 2, 3, and AVF. She went immediately to our cardiac cath lab here at Tufts. She was found to have multiple VFib arrests and a new occlusion in her PDA. Given all these findings, she was placed on VA ECMO via a 25 French right common femoral vein cannulation and a 15 French left common femoral artery cannulation for ECPR. Just as a quick review on VA cannulation, here this diagram depicts exactly what she had. She had a right common femoral vein venous cannulation placed for outflow, and then her left common femoral artery cannulation placed for inflow. Here's a zoomed in picture depicting what she got performed. Shortly after her ECMO cannulation, our surgical team got consulted for increasing abdominal distension and difficulty maintaining her ECMO flows. Lab work also depicted a drop in her hematocrit from 43 to 25. There's a bedside ultrasound done, which was concerning for possibly an intraparenchymal liver injury. At this point, I'd like to open the discussion for potential next steps.
Thank you, Dr. Tian. Dr. Antrak?
Yes, okay, so did you mention her vital signs? Hypotensive?
Yes.
I don't recall. She
was very hypotensive, requiring 30 mics of norepinephrine, vasopressin at 0.08, and the systolic pressures were around 80s. This is a patient who was in cardiogenic shock, and that's the reason she was in VA ECMO. But even with that, they were not able to maintain the blood pressure.
Right, and well, the confusion might be whether that's hypovolemic shock or worsening cardiogenic shock in a patient with a fresh MI. So I guess the ultrasound would help sort that out. How about the vena cava volumes? We're able to, and the ventricular volumes, we're able to see those initially, but I would look at that to see if it's a volume problem or the heart simply not pumping. But it seems like if she is bleeding into the abdomen, and also on the ultrasound, did she have hemoperitoneum? Did you see that?
No, they did not see hemoperitoneum. They saw, but they thought that the cannula was in the liver, and that's the reason they called it.
In the liver.
Yeah.
Yeah.
And just remember, this patient is in VA ECMO, So if the heart is not pumping, the ECMO should be able to compensate, but they were not having enough return from the ECMO cannula. And that was
yes.
they thought that they thought that the problem was the ECMO cannula.
Right. Yeah. So, so you say intrahepatic injury, and I guess we'll see what those images show. But it's a tough decision whether to go to the operating room for a laparotomy. If you find something causing the problem that you can fix, then you'll succeed. And otherwise, I think if it's cardiogenic and then she's having an operation, that won't help her. But based on the title of the presentation, there must be an injury from the ECMO cannula in the abdomen. I'm sure it's that. Probably, the hypotensive patient should not go to CT scan, and so it's a choice between operating room interventional radiology. I might consider interventional radiology to see if they can determine where the catheter is, the venous catheter, and whether it shows if it's in the liver or there's a blush from the liver. That might provide more information. But then the issue is whether they can do anything to correct it. So out of the two, I would probably say in this case interventional radiology, but it's something novel. And but I think that might give the best answer exactly what's going on, what kind of injury, and maybe is it something that they can fix by pulling the catheter back and maybe putting some kind of a covered stent, whatever. But I'll leave it at that.
Thank you, Dr. Antrak. Dr. Colette, Sao Paulo.
Yes, I think these patients need to make an image exam to show what exactly happened. What the catheter of the ECMO is have problem, because sometimes you have catheters that you put for dialysis, and the catheter can go through the pericardium, can go to the hetoperitoneum, and sometimes if you go to the hetoperitoneum, you can have some blending from the hetoperitoneum. You cannot see fluid in the peritoneal cavity. You can see only in the hetoperitoneum. And you need to know what the vessel is injured, because maybe arterial, maybe come some venous artery. These patients have inferior vena cava filter. Don't have it?
Yes, Dr. Colette, a very good observation.
Yes, if she has a inferior vena cava filter, when you put a catheter, you can mobilize the filter, and sometimes the injuries can come from the filter. And the filter sometimes have injuries of the venous wall, and may become some fistula through a hetoperitoneum. If it's a fistula from the hetoperitoneum, it's very difficult to fix it during the surgery. If a heterocava injury, sometimes you need more image to show what's happened. So I believe in this case, if the patients permit, the stability, hemodynamic stability permits, I need to go to an angio CT to see where is the problem. And then I come to decide what to do.
Thank you, Dr. Colette. Dr. Frisby?
Well, thank you, Dr. Calais. That was great. So they pushed the catheter up through the vena cava filter and tore the vena cava. Well, let's see. I don't have anything further. I'm gonna wait for this one. I think you're gonna need IR, but let's wait and see.
Thank you, Dr. Frisby. Dr. Kasim, Portland.
Dr. Hoffman, you should have named this iatrogenic medicine. And that's what this is. Several years ago, I came across a case of something like this following colonoscopy. I think it was the earliest report of splenic injury from colonoscopy. This reminds me of something like that. So the people who are doing the ECMO probably were not aware the inferior vena cava filter is placed below the renal. That is quite distal, and the ECMO catheter may have gone through it, or gone about it, or tore the wall of the inferior vena cava. Who knows? So the easiest thing to do would be very quickly here. You put some contrast through the catheter. It will tell you what the status of the inferior vena cava is, and it'll give you some kind of a inclination whether the vena cava wall is intact and where the vena cava catheter is lying and how far the ECMO catheter has traveled into the liver, etc. And I think this patient is bleeding till proven otherwise. And I think you should, I would be thinking in that term, and I need to stop the bleed if I want to salvage this patient. Thank you.
Thank you, Dr. Kasim. Dr. Machado, Michigan.
Well, thank you. I was going to ask the question of how long was the catheter, but it looks like there's an answer here that they selected a long biomedicus or something that reached the filter and created the injury. Dr. Kasim, I do agree with you that there has to be some angiographic assessment. However, you cannot inject the contrast through the venous cannula because the current is going actually from the patient to the machine. So you actually have to come either through the IJ, perhaps you have to do this under fluoroscopy with a headhunter type of catheter to actually direct the flow, direct the contrast to see exactly how the injury is going and from the head down to the IVC. And in that same time, I probably would say that that's how you probably can address it through a cannula, like a drainage cannula that comes from the top, and then you replace the one from the bottom. One interesting thing about ECMO is that it creates negative pressure. So if there's a tear or a wall tear, the catheter could potentially seal it off and buy you some time while the injury heals itself and it re-endothelializes. But it's going to require actually several services here to be on board, both not only interventional cardiology, but also a cardiothoracic group that is well versed in doing open ECMO, because if this is the only solution to actually provide a return cannula, you may have to actually open the chest and cannulate directly from the RA, the right atrium, to get drainage cannula in place to then clamp the proximal and distal IVC to correct this injury. But I have to say that ECPR with BEA ECMO doesn't sound like a great prognosis. So I wonder what is also the neurologic condition of this patient, and before we offer all these very dramatic interventions. So bottom line, interventional radiology in the fluoral with CT surgery on standby.
Thank you, Dr. Machado. Dr. Tian and Hojman, we go back to you.
Okay, just a few clarifications. The patient was very unstable. Initially, our plan was, okay, let's get a CT scan because that's the fastest thing to get. But we didn't feel that the patient was stable enough to go for a CT scan. So we make a decision that we were able, he was being massively transfused and barely keeping systolic blood pressures above 80. So we made a decision to take her to the operating room. So Tina, just go with the next one.
So exactly like Dr. Hojman mentioned, we went directly to the operating room for an exploratory laparotomy. Here are some of our intraoperative photos. Like many of you predicted, there was an IVC filter with the femoral venous cannula that had gone exactly through the filter. This is a zoomed in picture just to orient everyone a little bit with the anatomy here. The IVC filter is placed just distal to the renal veins. Here on the left side is our left renal vein, our right renal vein, our right gonadal vein, which had torn apart, and then the IVC filter here protruding through the inferior vena cava.
So when we explore, we we start mobilizing the liver based on the information we have. And after mobilizing the right lobes of the liver, we realized that the hematoma wasn't there, but was lower. So we did the Cattell maneuver, and this is what we found. And at this time, we say, oh, this patient has an IVC filter. We didn't know before. So it was on the record. So just to clarify, this patient, I was also upset why they put a long cannula if the patient has an IVC filter. And I have to say that the intensivist who put this patient on ECMO didn't know. He was called emergently to the cath lab in a patient that they were doing CPR, and they asked him, oh, put this patient on ECMO, and he did it as fast as he could without checking that the patient had an IVC filter. Nobody at the time thought anything about the IVC filter, and everybody forgot about the IVC filter until we found it in the operating room. And at that time we say, oh, this patient has an IVC filter, and we went and looked at the x-rays, and can you, okay. And this is the x-ray. So he had a very unusual type. I don't know if it's clear in the film. It's a very unusual type of IVC filter that the cannula, this is before essentially the cannula went through the IVC filter and deformed the IVC filter and caused tears in the wall of the IVC. So this is for the time of placement that they did this x-rays, but everybody forgot about this until we realized in the OR that we have this. So we didn't think that IR could retrieve this because the cannula was going through the filter, but we still called them. And we asked them, what do you think about this? And their answer was, even if the cannula is not there, this will take hours to take it out because they have to go for this type of filter. They have to go from the IJ and the femoral, and they have to collapse the upper part from the IJ and the lower part from the femoral in order to have the filter collapse enough to be able to retrieve it. So it's a very complex procedure to try to retrieve this type of IVC filter. So it will take several hours, which obviously not only we didn't have, but this couldn't be done because we had the cannula going through the filter. We were doing this in the hybrid room. We prepared to do this in the hybrid room. So interventional radiology was there, but they told us, sorry guys, we cannot help you. So this is what we have now. Okay, and I see in the next one. So we have, this is just as a quick reminder, this is the cannula and the IVC, and the filter is, the cannula is going through the filter.
Okay, I'd like to open it back to discussion for potential next operative steps.
Thank you, Dr. Tian and Dr. Hojman. Dr. Colette?
I think in this situation, you have the injury of the vena cava in the filter size is inferior vena cava. In these situations, I think you go to make tie the inferior vena cava in this moment and recover the patient. The repair of the vena cava in this situation is very difficult because the inflammatory process around the filter may be some difficult to make to put the reconstruction of this vein using the Safena vein or usually using a prosthesis like PTFE or something like this. I saw I see sometimes here I have said that the inferior vena cava filter can problems may be gone through the ball because it's near the duodenum. Sometimes they come make me injured to the duodenum. It's not very difficult to see it. Sometimes it's happened. So I think in these situations I go to tie the inferior vena cava.
Dr. Collet, the problem is that we cannot tie it because the cannula is there.
I will take the cannulas out and tie it. And put the cannula and put the cannula for venous part of sometimes I miss my words. Put the cannula through to the upper vena cava, superior vena cava. I change the place. Take the cannula and take the filter and close the vena cava and put the cannula into the superior vena cava place.
Thank you, Dr. Collet. Dr. Machado, Michigan.
Yeah, your problem is your drainage cannula is necessary to maintain this person's life. She's VA ECMO dependent. So you have to have some sort of drainage cannula, either like as Dr. Collet suggesting from the SVC, or like some cardiothoracic surgeons would do is open ECMO, meaning that you would do a sternotomy and drain directly from the right atrium. So, but at this moment, I think my question is to Dr. Hojman, is the bleeding stopped? You have the patient open right now, and you've, looks like you have the vessel loops around the cannulas, and the gonadal has the bleeding stopped. And I think that's the number one issue right now, is address the bleeding before we think about the cage or the IVC filter. Thank you.
Is that a question, or I'm not sure.
So the way I would manage is that I would leave the filter in place if it's not actively bleeding at this moment, because of the prognosis. All the prognosis is dependent on the VA ECMO, and that this lady can survive the VA ECMO run and can reperfuse, or that her heart responds. But other than that, to put her through a major operation and to try to reconstruct the cable or try to get this cage out of the IVC through a venotomy is going to be difficult, and is going to put her in even further risk of bleeding. So I would apply damage control principle in the sense that if the bleeding has been controlled, I would stop there and then continue waiting for her recovery from the VA ECMO standpoint.
Thank you, Dr. Machado. Dr. Kasim, Portland.
I have a little red book in which I put lots of names in there that I have met of people who can help me with a difficult problem. And I certainly would put Dr. David Machado's name in it. You know, he obviously is a fellow who is quite well versed with this. As a trauma surgeon, as a general surgeon, a vascular surgeon, thoracic surgeon, I haven't come across this kind of problem in my 38 years of career. So what would I do? I think I would call a friend, and I hope Dr. David will answer the phone if I do call him for this or something like this. So in the operating room, I am there and I'm faced with this problem. I have to ask two questions. One, how can I keep this patient alive? And number one, stop the bleed. Number two, keep the ECMO going. So of the two priority, both are important, but I think I need to get the location of this venous catheter moved from the area where I'm going to be doing some work to some other place so that the venous return can continue on to keep this patient alive. And one of the places would be obviously the right atrium. Second would be like you will do a renal dialysis, put a subclavian into the supravena cava. So having done that, what am I going to do with this disaster that I'm looking at? So I need to get rid of that vena cava filter. So the easiest thing that would be to get some wire cutter and cut the vena cava off from that, whatever you can, Because if you just remove it, you will tear it into shreds, and you wouldn't be very happy with that. And then remove as much as of the filter as possible, and leaving a shell behind, maybe very small amount behind, and then go ahead and ligate the intravenous cava and rely on the ECMO being perfused from the subclavian or the right atrium, whichever you want to do. And at least you would save the patient, and then you can think about what you're going to do next once you get the patient to the ICU alive. That's what would be going through my mind. This is a very, very difficult situation for surgeons like me and other surgeons who don't deal with this kind of problem. And it'll be nice to have a friendly voice from way up there in Michigan, from Oregon, at least, who could answer my call and help me. Thank you.
Thank you, Dr. Kasim. Dr. Frisby, Atlanta.
Well, I appreciate all the comments, and I too, I don't think I've ever run into this problem ever. So I would really need to, I'd probably use 2 or 3 telephones, but I would obviously need some help to decide, which would be, in the final analysis, the idea is to stop this bleeding and keep this patient alive. So I think Kasim and the other gentlemen have it on the money. I would have to defer to them, not having ever seen this before. That's all I have.
Thank you, Dr. Frisby. Dr. Untrak, Baghdad.
Yeah. So from what you said, Dr. Tian, the patient was bleeding from the gonadal vein and not from the vena cava. Is that correct?
He was bleeding from the gonadal vein, but he was also bleeding from holes in the vena cava.
Right. Okay. And you have control. So my only concern is, and I'd have to consult with the cardiologist and the heart surgeons. Would her heart tolerate the hemodynamic consequences of ligating permanently the IVC? That's my only concern. So, but in this, I agree with the others. You move the catheter to the venous catheter to the right IJ, remove the femoral catheter, and then depending on what the cardiologist said, if you could ligate the IVC and her heart would tolerate it, the hemodynamics of the ligation, fine. Otherwise, I think you'd have to try to do a repair, do a venotomy, try and remove the filter the best you can and repair it. Or if you could repair it, the holes without doing anything to the filter, that's a possibility. And I think you can just slip the catheter out, just withdraw it. Shouldn't be a problem, I imagine, without that should be doable without causing further damage. But again, having not encountered this complication before, that would be the thoughts that I would have, and I would need to. It would be a sort of a committee decision, particularly with the cardiologists and the cardiac surgeons about what the least bad option is here.
Thank you, Dr. Untrak. Dr. Tian and Dr. Hojman, we go back to you.
I think Dr. Collet, I don't know if we...
Oh, Dr. Collet? He...
I have a...
Yeah.
Yes, I have hope.
Okay.
Yeah, he was the first one, Dr. Hojman.
Okay, sorry. No, so I saw, Dr. Collet, that you wanted to say something. Sorry, I apologize. Okay, so this is the situation that we had. We had bleeding from the gonada that was ripped. I don't know, would you mind going back to some of the pictures, the operative pictures? Yeah, so we have bleeding from the gonadal veins that we ligated, but also each one of the vertical parts of the filter had a hook at each end. And posteriorly, those hooks caused a tear in the IVC, and it was bleeding from the back. So we had 2 concerns at that time. One, the filter was obviously deformed by the force of placing the cannula. So we were concerned probably wrongly so, that part of the filter might embolize to the heart, which is something that happens sometimes with filters. They embolize, and there are very serious consequences because they get lodged usually in the tricuspid valve, and kind of like that was a bad option. But we consider, okay, let's put stitches around the holes, around the hooks, and do like purse strings around the hooks and get out of there. That way, hopefully it doesn't embolize. But the other concern we had is that if we leave the cannula there, what will happen when the cannula was removed? And so we debated those two options for a while. And eventually we decided to open the IVC and remove the filter. And as you can see, with part of the filter already extruded, that was probably not a good idea. And we opened the IVC, and after we have hold on. So we say, okay, let's open the IVC and remove the filter. And this is when the anesthesia team who was in charge of the ECMO, they told us, you cannot open the IVC because the ECMO circuit does not have a trap for air. So if you open the IVC, the air that is being sucked from the open IVC will go straight into the arterial circulation. So this is where we took a moment to pause and decide what to do. And just keep going. Where were we? So we eventually we realized that the only option that we have was to use a cardiopulmonary bypass machine. As Dr. Machado correctly predicted, we need to call cardiac surgery here, and cardiac surgery place a cannula into the right IJ, and after this connected with this, we put a Y connector with the venous cannula and turn off the ECMO circuit. After this was done, after the patient was in full cardiopulmonary bypass, which is essentially the same that we were doing before, except that the machine has a trap for air, we open the IVC, partially, the catheter was partially withdrawn. We removed the part of the filter that was all deformed. But the problem when we opened the IVC was that we have, just talking about bad luck, just posterior to the filter, which you were thinking, why this is still bleeding if we have everything proximal and distal control? We have two really big lumbar veins coming posteriorly to the filter. Normally, that shouldn't be a problem because we will rotate the IVC, except that we couldn't rotate the IVC because the filter was preventing the rotation. So in cases like this, I would probably extend the venotomy and give myself enough room to put the stitches. But here, the extension of the venotomy was limited by the top of the IVC filter above and below the area that we opened. So we open, despite being in cardiopulmonary bypass, we run into this problem. And what will you do?
Dr. Kasim?
Dr. Hoffman, you must have felt like you were in a nightmare dream. I have been in a situation like this in my career a couple of times, and I felt like crying sometimes, you know what to do. Especially, you know, when you encounter a problem that you have never seen before or heard of before, it becomes a challenge. How are you going to deal with this? And like I said, you know, this is when Dr. Frisbee is right. Several phone calls to get help, to see what the solution is going to be. Now that you have managed to put the patient on cardiopulmonary bypass, and you have an open IVC, and you have two lumbar veins coming from below, you could possibly open the IVC and do an inside the IVC suturing of the lumbar veins. Sometimes that works, sometimes it doesn't. It makes the problem worse because it tears easily when you do that, and then you are in serious trouble.
This is what we try to do to suture the lumbar veins from inside. The problem is the venotomy that we were able to do was limited by the top and the bottom of the IVC filter, because I don't know if you remember that IVC filter has a top and a bottom. So we couldn't go above that. So the venotomy in the IVC was very small, and it would fill with blood very, very quickly, and we almost have no room to put the stitch. The needle and the needle holder were kind of like too big for the hole, particularly because we were working under blood, and we couldn't collapse the IVC at that area to trying to get better exposure. We couldn't extend the incision in the IVC. We just had the tiny incision with a cavity that was the limit of that cavity essentially was the contours of the IVC filter. And that was filling up with blood very, very quickly. Even with the suction, we couldn't catch up.
Well, I think I would partially remove the IVC. I hope that it is amenable to be able to cut the IVC filter as much as possible, and then patch the IVC with a saphenous vein or a graft or something like that, and get out of there as quickly as possible. That's what I would do. It probably won't be sufficient, and I think I will be tempted to do the best I can to get the patient out of the OR to ICU alive. And like Dr. Frisbee said, I would be waiting for making several phone calls to friends and foes alike and see if they would help me. Thank you.
Thank you, Dr. Kasim. Dr. Ontrak?
Yeah, so I would possibly consider a variation of what Dr. Kasim just said, and that would be maybe speak to the my transplant friends and what they do during a transplant. They put the veno-venous shunt from the below to above, and then ask them about that, and then go ahead and do what Dr. Kasim said, open the vena cava, remove that portion, ligate both ends, and then the patient, you don't have to worry about the hemodynamic consequences. They'll have adequate blood return, and let her get better, regroup, do what they need to do to the heart, and develop a strategy from different perspectives of all the specialists. But I agree, can't spend too much time.
Thank you, Dr. Ontrak. Dr. Machado?
For full disclosure, I do have an embarrassment of riches, so I would call many friends here at Michigan, and Dr. Bartlett is still alive, so I would call Dr. Bartlett as well, one of the pioneers in ECMO. But I think I concur with many of what's been said here. Interrupt the IVC with a proximal distal ligation, and use the wire cutters as what Dr. Kasim is saying. Perhaps it requires some sort of patch type repair. It is a low pressure system, so it can tolerate this type of repair, and get out of Dodge as quick as possible, because I think we're losing this patient. Well, we already have lost this patient 3 times with the cardiac arrest, so I think we're heading into that direction if we continue having this patient on table. Thank you.
Thank you, Dr. Machado. Dr. Frisbee?
Could I see that picture of the actual Go back one. There it is. No. Go. Yeah, you see the long struts on that particular IVC. Can you not take a wire cutter and remove those long struts to give you some room in there?
Can you go back one to the problem is some of those non-struts were extruded with time because the filter was there for a while.
Oh,
I don't know if you can see there on the picture,
yeah.
the two anterior struts were completely extruded.
I got it. And the lumbar veins are in the back.
Yeah, the lumbar vein. So it's like two cones at each end. So we make an incision, essentially was the length of those struts, but we couldn't go higher or lower because of the end of that IVC filter.
Well, I agree with all the previous comments. You know, you need to get this patient off the table if you can. As far as you know, I think the kidney transplant people would be somebody to call because they do jump these things every once in a while. But I don't have any experience with it at all. I'd have to call somebody. That's all I have.
Thank you, Dr. Frisby. Dr. Colette, Sao Paulo.
May I ask a question? Sometimes you have different types of inferior vena cava filter, and some filters you can exchange, you can try to take it out, and you can use endovascular catheters, and you can catch the filter and close the filter, and then you can take off the filter. I don't know if it's possible in this kind of the filter, but I think is one possibility. You can make an endovascular and try to close the filter and then try to take it out through endovascular. So the patient is cardiopulmonary bypass. You can sometimes have time to take this out. So I think sometimes you can go to endovascular to try to take this filter, and then you repair the vena cava.
Thank you, Dr. Colette. Dr. Tian and Dr. Hojman, we go back to you.
So yeah, we call interventional radiologists. I think I mentioned at the beginning, and they say that they couldn't take it out. First of all, I don't think that they would have been doable because the filter been there for so long that it was outside the IVC already. But they say that it will take at least 2 hours because they need to work from above and below to take it out. And he has the cannulas. He had the cannula in the inferior vena cava, and now he has a cannula in the superior vena cava. So there was no access to do anything like this. So what we ended up doing is, it was bleeding too much, we couldn't see, so we just grabbed the filter, pulled the filter out, get the wire cutter, cut whatever we could cut of the filter, got 2 pieces, one from above and one from below. The pieces, the filter was very deformed from the cannula itself. So we got 2 half, one on the top, one on the bottom. The parts that remained were embedded into the wall of the IVC. And after that, we closed the IVC primarily super quickly. That was why through the bleeding, we closed the IVC, and we put 2 stitches around two of the hooks, kind of like a purse stitch, and 2 of the posterior hooks, packet, and we got out.
After that, we performed a temporary abdominal closure with plan to return back to the operating room the next day. On the second postoperative day, we did return to the operating room after continued resuscitation and stabilization for a second look laparotomy. At the time, the IVC and the abdomen was completely hemostatic. However, given the persistent pressure requirements, we decided to perform another temporary abdominal closure with plan to return back for a 3rd time. Unfortunately, on the 3rd postoperative day, the patient was noted to have persistent bilateral lower lip twitches. An EEG was performed, which showed severe diffuse nonspecific cerebral dysfunction. And unfortunately, a CT head showed worsening diffuse axonal brain injury, as well as an acute cerebellar infarct, most likely in the setting of her prolonged hypotension. Post-op day 4 from the initial surgery and 2 from the second take back, we performed a palliative bedside abdominal closure. Family discussions were held, and after these, the goals of care were changed to comfort measures only.
Dr. Collet, would you like to make final comments?
Yes, it's a very, very, very great case, very difficult to say. And today, we will have more procedures that you can have complications. And you can sometimes you have to know how to treat this complication. Dr. Hojman, it's very, very nice case. Thank you to share the case with us. And I think it's very important because sometimes you try to using more equipments to treat patients, and sometimes the equipments have problem, and you sometimes I don't know, or I think I know how to treat this complication. So it's very important to know these complications and how to treat this complication. I see one case because I was working in the verification of death in the hospital. I see a catheter of hemodialysis can make injuries of the left and right ventricle, and can see the catheter in the necropsis through the right ventricles. And because the problem is the patient was working with this, and sometimes the position and the suction of the catheter may be injuries of the heart, and maybe injuries of the vessels where they were. So it's very important to know and very difficult to treat sometimes. And I think we are going to see more cases like this. Congratulations for presentation. Congratulations for your treatment. Thank you.
Thank you, Dr. Collet. Dr. Untracht, Baghdad.
Yeah, so I think even going in, a patient with all the background that Dr. Tian presented initially, when it gets to needing ECMO, that's in view of everything else, it's a very poor prognosis anyway. And the only issue is whether, how common is this complication? Is this a reportable case? I mean, I'm sure you looked, and maybe it's something to report. And then the other issue as well, should you, patients that have had a lot of procedures before you put ECMO, should you do a KUB? I don't know that anyone would advise doing anything differently in this case. If it wasn't immediately apparent, looking at the records, that she had the IVC filter, then it's just, I suppose it's one of those things. But I think the prognosis was the same, even had she not had the IVC filter, had it been recognized, and they put the venous catheter from above, unfortunately. But very interesting case, and thanks for presenting it.
Thank you, Dr. Untracht. Dr. Frisbee, Atlanta.
Just a couple of things. Number one, this is that's really a brave thing that you did. Tried everything. And number two, I'll never forget my major professor who used to say, when somebody tells you this is a really good case, run from it, because God protect you from a really good case. It was, however, bravely done. Nice case. Well done.
Thank you, Dr. Frisbee. Dr. Kasim.
Adding to that, number three, in a situation like this, when the interventionalist, the fellow who's going to put the ECMO catheter, was presented with, there was a big drama going on, cardiac arrest, resuscitation. Yeah, there is no time for him to think clearly with all his cerebral cortex firing together. Is there anything else this patient had that I should know before I put this cannula in? Such things doesn't usually go through our mind, at least doesn't go through my mind. Maybe it should. And I think maybe Dr. Untracht is right. Get a KUB or get a chest X-ray before you do any intervention to a patient in situation like this, so that you can avoid this? I don't know. I don't know what the answer is, but I must congratulate Dr. Hoffman and his team to give them credit for doing their very best to salvage a very, very difficult case right from the beginning. She should have been dead 3 times before even before he was called, but still he gave it his best, and the best was not good enough because the patient's protoplasm didn't work in her favor. So, Dr. Hoffman, you did your best. So I congratulate you. Thank you.
Thank you, Dr. Kasim. Dr. Machado, final comments.
Thank you, Dr. Hoffman. This was a very important case. I agree that this is going to be part of our practice in the future. If you look at the recent algorithm for ACLS, eCPR and ECMO is part of that management tree. So we're going to get more and more calls about this nature. I just want to mention that immediate complications of ECMO placement are related to the implantar wire. This wire is very hard, very sturdy. It can perforate absolutely every single organ intravascularly as well as extravascularly. The midterm complications are related to the circuit itself. So it could be things like bowel ischemia and compartment syndrome. And then the long term are related to the anticoagulation and the biotrauma from the ECMO circuit. So you can have things like coagulopathy of unknown reason, and it's just the ECMO circuit causing spontaneous bleed, not only around the IVC and vascular structures, but also intracerebral, spontaneous mesenteric bleeds, etc., that are just related to ECMO. So we have to be very vigilant about these patients and be clinical suspicious that there could be a complication related to ECMO. But once again, thank you, Dr. Hojman, for bringing this up to the panelists and to our community, because we're going to get called more and more. Thank you once again.
Thank you, Dr. Machado. Thank you to all the panelists, and please take a moment to take note of the CME code that I'm sharing, and we hope to see you next week. Thank you very much.
Thank you.
Thank
Thank
you.
you, Dr. Hoffman. Bravely done.